Afternoon. Thank you all for staying and hearing about the take-home messages from our section. My name is Mitch Goldenberg. I'm a urologist at USC, and I'm joined by Dr. Kathleen Kobashi, who is the chair of Urology Houston Methodist. So I'm going to be highlighting some key papers that were talked about at the conference this year, and then we'll be getting some commentary. I have no relevant disclosures. So to start with, sacral neurostimulation has been around for a long time, and traditionally, non-neurogenic patients have been offered these therapies. Patients with a neurogenic bladder generally are not included. And so this group looked at a retrospective matched cohort of about 275 patients, and they stratified their neurogenic patients into progressive and non-progressive neurological patients. And essentially what they were looking at is whether the response to therapy would be adequate among this group. And this has been looked at before. And I think what came through right away is that the outcomes were very similar between the neurogenic and the non-neurogenic patients in terms of moving on from stage 1 to stage 2. Explants, medication tend to continue in the neurogenic group compared to the control group. But really the remarkable takeaway from this was that the outcomes at 6 weeks and the last known follow-up for the patients, the symptom scores sort of stayed low and continued to be durable even many years out. And what's even better about this is if you stratify the patients in the neurological group into progressive versus not, the non-progressive patients tended to do much, much better. And so while this has been examined in this population before, I think really by teasing out which patients do better, we're able to kind of identify those patients within our own practices who may benefit from these different therapies. And so I would argue that maybe we should expand the therapy to patients with neurogenic bladder. Obviously, being careful in our patient selection. So I'm not sure what your experience has been with these patients, but
I think, Mitch, over the years, I think many of us have actually treated patients who have, stable MS, for instance, and you code it as urinary frequency and urgency. That's the indication for it. It was not indicated for neurogenic bladder. The other caveat, of course, was that those patients need serial MRIs, many of them, and that was a factor, that was a barrier. But now that we've got MRI conditional implants ever since 2019 or so, anything that's implanted after that technically should be MRI conditional. I think it's a great option to offer our patients, and they do indeed anecdotally do well. Now this is a study that really shows this. I think that's going to crack the nut wide open and give an option to patients who can really benefit from it.
Right, so maybe not changing what we're doing already, but certainly lending credence to what we do, so that's great. Moving on to pelvic organ prolapse, this was a interesting study that personally challenged my notion about when we should be putting mesh into patients. Traditionally the way we think about this is if you're going to open up the vaginal wall, you don't want to put mesh in at the same time. This group challenged that notion by looking at patients undergoing radical or total abdominal hysterectomy and looked at over 100 patients. And they actually found that, in fact, in their cohort, the mesh exposure rate was equivocal, basically, to those patients to sort of what our understanding of the mesh exposure risk is, in the 5 to 10% range. And they actually look at patients up to 8 years post-op. And what I took away from this in particular is that there were actually a small number of patients that had pelvic RT either adjuvantly or preoperatively, and there is actually no mesh issues in those patients. So again, not only opening up the vaginal wall, but actually in patients with a history or who are going to undergo something that we consider to be very high risk for mesh problems, they actually did quite well. And then when they looked at the durability, again, quite comparable to sort of what we would expect from a mesh abdominal surgery, with a failure rate of about 11% over the 8-year period. And actually only 2 of those patients underwent any subsequent surgery. So even though the prolapse rate postoperatively was around 10%, the actual rate of bother was quite low. So for me personally, in my practice, there are patients that you come across who you think maybe they do better with a total hysterectomy, long cervix, bulky uterus. And so, these patients potentially could be candidates now for mesh repair at the time of surgery, as opposed to delaying that and doing something different. I'm not sure if you have experience with this.
I mean, we do concomitant sacrocolpopexies on patients who have hysterectomy. I think the key is that you just don't want to overlay your mesh on the suture line, obviously. So if you can like avoid putting the mesh in the closure of the cuff, I think that you're fine. What I found surprising here is that there was a little bit higher erosion rate on the non-cancer patients than the cancer patients. But I think it's a great idea if you're there already. You don't want to have to ever go back into that area. So while you're there to do that prophylactically, I think is a very reasonable thing to do.
Yeah, and there's data from the cancer world as well for patients undergoing radical cystectomy who have their vaginal wall open, and then they put mesh in for them, and they tend to do quite well too. So more evidence for what we're doing. Shifting focus, this is a study out of Dr. Creighton's group, where his interest is looking in the neurological function as it pertains to bladder function. He did a study that was quite a undertaking. He did a functional MRI while doing UDS filling cycles on patients. So you can see in the graph here that there's the green shaded areas per mission given to the patient. So those are voluntary bladder contractions. And then you can see on the top line, it's a little thinner. There's not a lot of lineup with the voluntary phase of the study, and yet you can see the bladder contracting away there, and that's an involuntary bladder contraction. And so what Dr. Creighton did is he did bold signaling and found that even in stroke patients, when they're given when they're allowed to actually have a bladder contraction, the signaling looks quite comparable to healthy patients. But if you look at the involuntary contractions, this salience network, which is a sort of key component in interpreting external signals that we come across, it's sort of absent. So in involuntary bladder contractions, there's a clear absence of this salience part of the tracts. And this to me sort of speaks to the fact that this could be a great target for future therapies. I know there is already some transcranial therapies out there.
Actually, this is fascinating to me. Just when you think there's nothing else to discover, somebody comes up with something like this. So there are several centers around the globe that are looking at, correlating functional MRI hotspots or whatever during overactive bladder contractions, or even as a patient walks or as an individual walks into a bathroom, that sort of triggers some functional MRI spikes or whatever you want to say. It lights up in certain very reproducible areas. To your point, Mitch, we're doing, one of my colleagues, Dr. Kobashi, is doing transcranial work. So now that we've been able to identify areas of interest on functional MRI, you can target them. And so now we're targeting with transcranial caps. You can target areas of interest, and so to control overactive bladder. So, I mean, that is the future, right? The future's here, and this therapy is really right on the horizon. So, fascinating. And Dr. Creighton is doing fantastic work in this space as well. So, more to come on that.
And we'll keep moving forward here. This is a very challenging group of patients to treat. So these are the IC patients that you come across with Hunter's lesions. So not every patient with IC will have changes in their bladder that look like this, but this group was sort of dedicated to identifying novel targets in patients who have Hunter's disease within their bladder. And what they actually did is they did sequencing on these patients. They took 12 patients with lesions and 7 without, and they took blood samples and looked at HLA expression in IC patients, and specifically those HLA alleles that target the uroplakin protein. And uroplakin is a key component of urothelial function. And when uroplakin is not functioning normally, that's often when these sort of inflammatory changes tend to happen. And so not only were they able to identify 2 key HLA targets, but they actually looked at the binding sites on different uroplakins and found that there were actually quite a number of them that they were able to find. And when you look at the actual 3D modeling here, you can see targets on the uroplakin proteins themselves where these HLAs can bind to. So this is obviously a little bit above my personal pay grade, but I think it's very cool that the immunotherapy angle of treating IC is something we've always thought about, but now we actually may have novel targets that we can develop drugs for. And it also raises a lot of questions for future studies about whether immunosuppression leads to improved outcomes in these patients. And there's some experience with that already, but I don't know if
Yeah,
if
no,
you have any
I
comments.
agree. This is fascinating work above my level too. But I mean, if we can identify these targets, I mean, this is such a challenging group of patients that you really want to help, and they've got this terrible pain syndrome, and we just don't have anything that's dependably successful yet. So as we jump into the future and we start to target these, or identify these potential targets, I think that would be a game changer.
And I think these patients, we tend to treat them with more of an anti-inflammatory approach, but this more gets to the source of why that inflammatory process may be there. So I think it's very cool. This is a sort of novel device that's been presented at meetings in the past, but they have some data that they wanted to share at this conference. This is a patented transvaginal device that allows RFA treatment in the sort of autonomic nerves that tract into the back of the bladder. And sort of the proof of concept has already been published, but this was some patient data that they wanted to go over. And so they actually enrolled patients with pretty typical urgency symptoms. They had to have at least one urgent continence symptom, per day. And they excluded patients who had had prior transvaginal treatments. But essentially what they were looking at is their sort of 6-month data. And they found that they actually improved over time across patient outcomes, urgency, and urge in continence also. So pretty much across all the domains at all time points, these patients are doing better. This is an angle that it's not part of our treatment course that we talk about to patients now, but maybe this transvaginal RFA, the pain scores were low. It's done in the office. So potentially a great new tool that we can use.
Yeah. Very interesting, different way of doing neuromodulation, right? Rather than modulating through the afferent pathway, they're actually ablating the nerves that are creating that, I guess, efferent nerves that are creating the overactive bladder, the actual contraction. So again, amazing that we're thinking about all these new novel approaches. This looks, with the data as promising, the early data, I think it's something that's easy to do. It would be easy to do in the office, and something that, again, may offer our patients yet another avenue.
Yeah, and the group comments, obviously, they want to report longer data, but at 6 months, you start to see a trend back towards sort of the mean a little bit. So, but hopefully in longer term studies, they can show that the treatment effect is still there. If we think about comparing it to something like botulinum toxin, right? That's about 6 months of duration. So if this could be similar, then that's probably good enough.
I mean, I guess the question is going to be, if it's ablating the nerve, what's going to be the long-term effect? If you want to do it in males who later are going to develop some prostatism, is that going to create a problem with contractility? I mean, we just don't know that yet.
Absolutely. Harder to get to the trigone. This was a really great study. Dr. Warnerberg, who's now a fellow, but he's been presenting this data for years, but this was their most recent data that they came forward with. And this is looking at the microbiome in patients. And what they found is that OAB patients express very different bacteria than sort of the healthy controls. So not only did they show that even in menopausal patients that this difference is still there, meaning this is not an age change, that difference exists across different phylum, genus, and also species, with lactobacillus being much more common in healthy patients, which I think we would kind of expect. And not just that there's differences in the expression and the types of bacteria that live in these patients, but also, this is really the coolest part of this, is that lactobacillus concentration can predict response to therapy. So this was botulinum toxin and sacral nerve stimulation, and they found that certain concentrations of lactobacilli, these patients actually did better. So not just that there's a difference, but that treatment effect might be impacted somehow by this. So if we can manipulate the microbiome in these patients to improve their response to therapy, or just use their microbiome to identify who's going to do better with certain therapies, I think that's equally cool, and improving outcomes in these patients.
Indeed, I agree with that. We've long known that the microbiome can it is, well, we've known that the microbiome can be different in patients with overactive bladder versus not, or with patients who have chronic urinary tract infections, et cetera. But if we can manipulate that with probiotics, I think that could be a nice preventative thing that's not, without poking and injections and all of that. I mean, that would be a wonderful thing. Again, another game changer.
Right. And then finally, I think this was the key thing to highlight as part of this talk. This is a guideline that was published yesterday, a long time in the works. And so I wanted to highlight that to the room. GSM is such a prevalent, common patient group that we see and that we treat. And it has a huge impact on the healthcare system, billions of dollars a year in infections and patient pain and impact on quality of life. And I think there's so many simple things that we can do to help these folks. So it's, first of all, it's about understanding who these patients are, who you need to screen, and then how to assess them when they come to your office. The guidelines do a good job of highlighting it's not just about the medical history, it's also the sexual history, psychosocial, and then doing an exam. These patients, you need to confirm what's going on. It's in fact, not so much to confirm that they have GSM, but more to exclude other things that you may need to treat separately. And then trauma-informed care. This is a new concept to me that I got to read about when I was getting this talk ready, but essentially, and I think it's something that a lot of us do already, which is that these patients are often, being a victim of trauma gets you at higher risk of having GSM. And so, you want to be careful in how you meet these patients, how you talk to them to ensure you're not going to trigger them, and also not push them out of your office. There's patients who don't seek care because they're afraid of having a pelvic exam or even talking to somebody about their symptoms. There's a lot of shame, and so you want to be very careful with the type of language that you're using. The guideline also does a great job of outlining the treatments that are out there, and this is something I encourage you all to take a photo of. I see a lot of you doing that, because these are all such simple therapies. I mean, these are therapies that we prescribe day in and day out, and they're easy to give, they're safe, and patients tend to be pretty compliant for the most part with them. The side effects tend to be rare. In particular, what they stress is that the serum level of hormone is very low in all of these different therapies, and that's something that most patients are a little bit concerned about, especially if they have a history of breast cancer. That's a topic that we have to talk about a lot, and the guideline makes it extremely clear that these patients are not at any higher risk, and that while you need to incorporate their cancer team in making these types of choices, you can prescribe them, and that they are safe. And so it gives you a lot of backing to talk to the patients when you have a guideline like this. So in terms of the key takeaways for me, be proactive, offer patients therapy, it's safe. There's sort of non-estrogen therapies for certain patients. DHEA cream can be quite good in these patients. And then an oral therapy, which is a SERM, that can be used in patients who don't want to use a cream. Energy-based therapies, which have been popular in the last few years, I think are kind of out of vogue. There's not a lot of data to support them. The trauma-informed care approach that I talked about, and that these patients don't need to have any extra surveillance, mammograms, pap smears, anything like that. So this is safe treatment. And just to highlight again that this is simple, safe, and easy to use, and you will have a huge impact on your patient's life. And I know you've been doing this for a long time. So.
No, I agree with that. I urge you all to incorporate local hormone replacement therapy for your patients. And like Mitch pointed out, it's safe even in patients who have breast cancer. I always, check with the oncology team just to make everybody feel better about it. But rarely do I get a no on that because the absorption is minimal to none. I think, it's great for patients with, vaginal dryness and lubrication issues, but it also helps with overactive bladder, urinary frequency, recurrent urinary tract infections. It just really gives you a great bang for your buck. So I urge you to incorporate that, and we are at 0 minutes. So I think Perfect. With that, we'll pass it on to the next team.
Thank you all so much.
Thank you very much.